We'll finish up chapter 42. There's not a whole lot left, to be honest with you. But don't forget, Wednesday then we'll have our next test. And looking at the test, making the test over the weekend, I'm like, oh man, there's a lot of stuff here, right?
Yeah.
Oh wow, oh no. You have all the aerosol generating devices, MDIs, DPIs, Respimat, vibrating mesh nebs, small particle aerosol generator, whatever, large volume nebulizer. The other stuff I'm
So you're
forgetting
basically
to
saying,
mention.
what was I thinking doing this to them?
Nah, not really, but I do empathize with your pain of reviewing. We talked about all those different gases, the medical gases that we can potentially administer, and then of course this chapter, the devices that we're administering, obviously oxygen with. Being the main primary gas. So make sure you are reviewing that stuff, even going back and looking. Remember I said I could have some pictures, excuse me, on this test of whether it's some of the different DPIs. That's what always gets everybody in trouble. I give you a picture of a DPI, and then the question isn't identify the following MDI, DPI, small volume neb. No, it's is this the flex haler? Is this the twist haler? Is this the disc haler? Et cetera, et cetera, et cetera. Is this the haler, whatever other crazy names I can think of at the time. So make sure you do look back at that stuff. There are some things, like for example, a DPI does require a certain inspiratory flow by the patient to make it work, and if the patient can't generate that specific inspiratory flow, then a DPI is probably not going to be the best option for them. So don't forget to look back at that other stuff. Now, with chapter 42, again, sticking with the way the chapter breaks it down, low flow devices, reservoir devices, and high flow devices. Now, today's topic is kind of where we left off, with is high flow devices. So what are high flow devices? They provide all of the patient's inspiratory flow needs, whereas low flow devices or reservoir devices could provide only a part of the patient's inspiratory flow needs. And again, I'm emphasizing that word. I know it is in the term, but make sure you realize high flow devices doesn't translate to high FiO2, even though we could provide high FiO2s with them. It's high flow. Low flow devices don't necessarily provide low FiO2s, even though if you look at some of the numbers, yeah, that's probably going to be the lower end. Low flow devices provide lower flow, where the patient has to make up the difference pulling in and mixing room air. High flow devices, the device itself, and I will put an asterisk with this, as long as we set it up properly. Again, I can make a high flow device a low flow device by setting it up wrong. So assuming I set it up correctly, a high flow device will provide all of the patient's inspiratory flow needs. It will either meet or exceed the patient's inspiratory flow needs. With that, since the device is providing all the flow necessary, we will deliver a precise FiO2, a very specific FiO2 for the patient. Now you can say, but John, isn't with the rule of 4 a nasal cannula at 2 liters 28%? In theory, yes, as long as the patient's breathing pattern is ideal. But what if the patient's breathing pattern is not ideal? They're breathing really rapidly, they're breathing fast, they're breathing shallow, they're breathing deep, very inconsistent breathing pattern. Then that 28% is kind of a rough guess. If I'm providing a high flow device at 28%, as long as they're breathing, whether they're breathing normal or not, they're going to receive 28% with a high flow device. Now down here again, I just took the verbiage here from the textbook when it describes what a high flow device should at least provide. Should provide at least 60 liters a minute of total flow. With that, it's going to be very difficult for you and I, even if we're trying to exceed that inspiratory flow from us. Okay, so if we provide a device that provides at least 60 liters a minute, that's going to definitely meet or exceed our own inspiratory flow needs. In case you're curious where 60, that arbitrary number, came from, the theory is even if we breathe as deep and as fast as we can, we probably could generate 20 liters a minute of inspiratory flow. And so with that, so with 20, they say if you can triple that number with your device, so multiply that 20 times 3, that's where the 60 liters come from. That should be more than enough flow to meet or exceed your patient's inspiratory flow needs. And so we'll kind of hold with that number. When we're looking at a high flow device, probably a good idea to make sure that device can provide at least 60 liters a minute of total flow. I don't mean 60 liters coming from the flow meter, but of total flow going to the patient. All right, so high flow systems mix oxygen and air together to provide a given FiO2. Now these devices, high flow devices, can be through air entrainment systems or blending systems. We'll talk about the air entrainment systems first. I know you guys have probably talked about some of these already. The two most common is an air entrainment mask, otherwise known as, what's that mask that starts with a V? Venturi mask, or Veni mask for short. And I don't mind calling it a Veni mask or Venturi mask. You'll hear me say it in almost in a second sentence. I'll say air entrainment mask, and in the previous sentence I'll say Venturi mask. I'll bounce back and forth with my verbiage, and yes, saying a V mask or Venturi mask is simpler. But the reason in my mind I always keep trying to use the right word, trying to use the proper word, air entrainment mask, because that's what you're going to hear the MBRC refer to it as opposed to a Venturi mask. Now in the hospital setting, if I'm asking for something, I'm going to call it a Venturi mask. It's just easier to say that. If you were to call it a air entrainment mask to one of the therapists you're working with, they're going to pause for a second going, why are you trying to be so fancy and nerd, be so official, nerd, right? That's just, again, it's me trying to say that word more often than I say Venturi mask, so you can associate it when the NBRC calls it an air entrainment mask. Same thing as a Venturi mask. Air entrainment nebulizers, those are those large volume nebulizers. Well, I'll be able to talk about the FiO2 with those devices now when we get to those in just a second. All right, so how these air entrainment systems work. They direct high pressure oxygen gas through a small jet or small nozzle that are surrounded by air entrainment ports. Now, the amount of air entrained by these entrainment ports, again, remember, when room air gets entrained, it's going to dilute whatever that given FiO2 is with 21% oxygen, regular room air. And so when you see something like this, the high pressure, high flow oxygen going through the jet, it's the speed and the size of that jet orifice that determines how much room air gets pulled in, gets entrained in through that device. Now, I know you guys have seen Venturi masks, and what's the thing that's on the end that we keep looking at? We pop a new one in, we take the old one out, we look at the other one, we pop it in. What are those things? Those different the different colors, the different adapters that can plug on the end. We look at them because why do we stare at them? What's written on there? The FiO2. So I know what the FiO2 is going to be. It also gives me another number. Liter flow that I should dial my flow meter to deliver that specific FiO2. You can't, and I'll mention this about the different colored adapters, and many times we do, but it's probably not a good practice to do this. The different colors obviously mean different FiO2s, but you can't always trust that this certain color is always, say, 40% or 50%. A different manufacturer may make that same mask and change the color schematic around. So that's why you always have to read what's on the device. Just don't memorize the color of the adapter. Make sure you actually look at it. All right, so we've already called it a Venturi or Venti mask. Uses the air entrainment principle, again, small bore tubing. So coming from my flow meter, small bore tubing that goes to the jet, again, providing that high velocity oxygen gas source right next to these open room air entrainment ports. So it's the size of this jet and the entrainment ports that determine how much room air gets mixed in. Because again, what's the FiO2 coming through this oxygen tubing? What's the FiO2? It's 100%, right? It's coming from the flow meter. Flow meter, the FiO2 coming out of that flow meter should be 100%. So really it's 100% O2 going through this tubing. Now it's not 100% O2 that goes to the patient because room air gets sucked in, gets pulled into this device. So here is where the mixture occurs to deliver that mixture of oxygen to our patients. FiO2 range, this is important to note about the air entrainment mask. Max FiO2, typically around 50%.
Do those adapters take into account the air leaking through the entrainment ports? Or not leaking, but going through.
Being pulled into the entrainment port? Yep. Yep, absolutely. And again, as long as we set this up correctly, it will provide a fixed FiO2, an FiO2 that will not change, that will not alter, like an FiO2 of a low flow device can vary depending on the patient's breathing pattern. All right, so two different colored adapters. So this is us looking down at the adapter. Now this is something we typically don't do, but to explain what's on the screen, it's a good idea to recognize, oh yeah, there are different openings for the jet, okay? So I'll take the first one, the smallest jet, okay? Comparing the two, this one's larger, this one's smaller. The smaller jet provides the fastest oxygen velocity going through there from that small bore tubing. Fastest oxygen velocity, so speed, and it creates the greatest entrainment. Now what does that mean? Room air getting pulled in, 21% being mixed in with this gas. Smaller the jet, more room air gets entrained. What happens to the FiO2? The lower the FiO2 will be for that particular device. The larger the jet, right? Larger the jet, the slower the oxygen velocity, less room air gets pulled in, meaning you're giving more of your source gas, which is oxygen, so that tends to give you a higher FiO2. If I just look at these two adapters just based on the size of the jet, which one's going to provide a higher FiO2? The orange one or the green one?
Orange.
The orange one. Okay? It's going to cause less, because of that larger jet, it's going to cause less room air to get pulled in. Versus the smaller jet, it's going to cause more room air to get pulled into that device. And again, pulled in down here where those different colored adapters are. Now, small bore tubing, yes, but that will connect to large bore corrugated tubing that's really connected to my mask, okay? My air entrainment mask. Again, what's the maximum FiO2 this device can provide? 50%. So if your patient is really sick, needs a little bit more, this device cannot provide more than 50% oxygen, 50% FiO2.
Get notifications like crazy over there.
Not me. All right, air entrainment nebulizers, air entrainment systems. This is the thing we've talked about. We started with bland aerosol therapy in one of the other chapters that we did, even that we're not including on this test. We talked about it with not this particular type, but there's some large volume nebulizers that can be medicated. Not this particular one, but some medication can be placed into large volume nebs. This one is the one that delivers the brand aerosol therapy, but with the adapter on the top. The adapter that I tried not to say too much about in chapter 38, 39, whatever that number was earlier. Now this device, again, connected to my flow meter, so it's pneumatically powered, does use the gas source, pneumatically powered. The air entrainment ports are right here. And so depending how I dial it, and again, it's kind of hard to see that little arrow pointing to the FiO2, but depending where I dial it to, it's going to tell me what FiO2 that device will provide to my patient. The ports here on the side will open or close depending on the amount of room air I'm allowing. So as opposed to having to change this out for every single one, like the colored adapters with a Venturi mask, this is all in one. I'm basically changing the size of the air entrainment ports. And if you ever get a chance to mess with this, you guys got a chance to set these up in the lab at some point, or if you haven't, you will in time. You can hear it. If you have it turned on, connected to a gas source, you have the flow flowing through it, you can hear it when these air entrainment ports are wide open because it's loud. You hear the air going through. When you close the air entrainment ports, guess what happens to that noise? It gets really quiet because you're not pulling in as much room air anymore. You're giving more of your source gas, which would be oxygen. Now, for my patient on a air entrainment mask, Venturi mask, that my FiO2 max is kind of tapped out at 50%. My patient needs a higher FiO2 than that, then maybe I could switch to a system like this. And it could provide on the low end of the FiO2 range all the way up technically to 100% oxygen. I think this particular one, I think its maximum is like 80, 98%, something like that. But in theory, it could provide almost the gamut of the FiO2 ranges here. And again, provided, don't forget the devices. This is known as a aerosol mask, T-piece, face tent, trait collar, all the different interfaces connected to that system, right? Large bore corrugated tubing, the drainage bag. Okay, so don't forget that's how that system functions. Again, all simply to provide a different FiO2 depending on what the patient needs. But it is a high flow device, so we'll provide a fixed FiO2 to our patients. All right, so how do you know if the flow is adequate? Okay, being at the bedside, looking at the patient with one of these air entrainment systems, how do you know if the flow is adequate? Now, because it's delivering a bland aerosol, you should be able to see the aerosol. Now, sometimes it's difficult, sometimes it is challenging. I think I used this analogy before, holding the tubing against maybe a darker background, against the white wall is hard to see it sometimes, but against a darker background, sometimes you can see that mist or that aerosol. Sometimes, especially in a lab setting, to really make it stand out, I'll turn the flow meter down really slow so you can then start to see the mist, but when you turn it up to the flow meter setting, it probably really, that flow of gas, that aerosol really goes fast and it makes it harder to see. Anyways, at the bedside, you can look and see if you're providing enough flow for your patient without doing any math, without doing any calculations. T-piece is probably going to be the easiest way to see this. You can still see it with trait collar and aerosol mask, etc. But a T-piece typically is the easiest way to see it. So as this is coming from the wall in the air entrainment nebulizer, there's constant flow going through here, correct? Okay. When the patient inspires, they're going to inspire what's going through this line. Now remember, this piece is only 6 inches of reservoir tubing, so it stops. This piece is 6 feet of corrugated tubing going to my air entrainment system. There's going to be constant flow. When the patient inspires, they're inspiring from the flow that you're providing. Now on this end, if you ever notice the visible mist completely disappearing, that means you have not provided enough flow for your patient. Because you're seeing this visible mist completely disappear, the patient's pulling in room air. You're not providing enough flow. So how do you increase the flow to the device? Increase the flow on the flow meter, right? Increase the flow on the flow meter. Now, those that have seen a standard nebulizer breathing treatment, and the corrugated tubing, and again, the mist coming out the end, and the patient inspires the medication, and you see that mist disappears. It's the same concept, but with that system, that's okay. I don't care that the mist disappears. I don't care that they're pulling in room air. Because again, I'm giving a breathing treatment of medication. I'm not trying to provide high flow like I would with a T-piece type system. The other systems, the air entrainment mask, the trait collar, you should still be able to see the visible mist. Again, it's challenging to see it sometimes, especially when it's going through so fast, but as the patient inspires, again, if the mist was to disappear, well, let's say it's a trait collar, you see that mist completely disappear when the patient inspires, you have not provided enough flow to the patient.
On the adapter, when you dial to whatever flow, whatever FiO2 you wanted,
Yep.
it says like the flow 8 liters. So if I see that it's not going, it doesn't matter, I can go up.
I'm glad
It's
you
not
asked that
gonna,
question.
it's not gonna match.
I'm glad you asked that question. Let me go back to it. All right, so on this dial here, so does that say 40%? Is that what it's kind of pointing to? I think
Yeah.
so. All right, so 40%, it tells me to set the flow meter to 10 liters here. That's a recommendation where it should be set. If I go higher than 10 liters, if I turn it to 15 liters, am I changing the FiO2? I am not changing the FiO2. I'm just increasing the flow going through the system. I don't want it to turn it less than that, but 10 really, and I say this, 10 is the minimum recommended range, but what if my patient really needs more flow? And I notice, even though I set it to the way this is set up, I notice that mist disappears, I can still increase the flow to my flow meter. And it's not changing the FiO2. It's only changing the total flow going through the system. Okay, but it's not changing the FiO2.
Is there like a max though? Like,
As
will it
far
be-
as you wouldn't want to go higher than
Yeah.
X, no. There is no danger increasing the flow to the device. You're not altering the FiO2. Okay, the FiO2 is still going to be 40%, 50%, whatever you have dialed in. You're just providing excessive flow that's just going to go out into the room, and the patient's pulling from that flow. So it's not gonna, you're not gonna blow up a patient's lungs or anything like that, because this is not a closed system. So I guess the only, I'm trying to, in my head, come up with a drawback. The only drawback, and again, it's very remote. Again, we just went through an experience now 5 years ago that this would make a difference. If you have the flow in excess of what's necessary, you're wasting the oxygen. You're wasting the oxygen. So think back COVID when we were trying to conserve oxygen and not, again, okay, in that situation, I'd be a little more conservative. I still want to provide, meet or exceed the patient's inspiratory flow needs, but maybe I don't necessarily need to increase the flow up to 15 liters because then I'm just using up the oxygen. But generally speaking, now today, yeah, I'm not worried about it. We have plenty of resources, plenty of oxygen that we can get in, but again, in a crazy world situation like we experienced 5 years ago, that we hadn't experienced decades prior to that, I would say no, there's really no
Has
worry.
it really been 5 years?
Well, since COVID,
Yeah.
yeah. Hard to think about that. Seemed like it was just yesterday. Let me get through that. All right, so total flow calculations. No, I can't leave it alone if there's an opportunity to calculate something, right? Calm down, I can see your excitement. I saved it for Monday. All right, so total flow can determine whether this device is a high flow device or not. Now, with air entrainment devices, we can calculate what the air to oxygen entrainment ratio is. Okay, that's an important number to note. How much air, the way I have this device set up, how much air is going to get pulled in with this particular system, the way it is set up right now. And that is something, I know Desmond has introduced some of you guys to this already. If you haven't heard it yet, you're getting a head start from me. Desmond will still review it with you guys. If you've heard Desmond's review, you already talked about this. This hopefully just kind of hammers it home the rest of the way. So, to determine the ratio of air to oxygen being mixed, we need to calculate that first and then multiply that by the liter flow coming from our flow meter to determine what the total flow is going through our system. Now, what did we say very first slide? To be classified as a high flow device, we should provide how much flow? Approximately 60 liters. If our device can provide 60 liters, that's going to fit 99.9% of our patients that require a high flow device, including ourselves. Anything less than that, again, the way you and I are breathing right now, pretty calm, pretty relaxed. I know we don't need 60 liters right now. So in those situations, okay, maybe a little less than that's not going to be overly harmful. But again, to make sure I meet or exceed any patient's inspiratory flow needs, generally you want to make sure that flow is at least total flow is at least 60 liters a minute. All right, so how do we calculate this? All right, so did you notice there was 2 formulas on the screen? Desmond may have only shown you one, right? All right, so I'll use, I guess it doesn't matter. I'll start here. So to figure out the air to oxygen entrainment ratio, you take 100%. That's a given in this equation. Take 100% and subtract it from whatever the FiO2 is we're trying to provide. Whether it's 50%, 40%, 80%, whatever the FiO2 we're trying to provide. I'm going to divide that by that same FiO2 subtracted from 21. Okay, now you'll notice if I just bounce down here, this one just simply uses 20 for simplicity's sake. I think it's easiest to use 20, right? Easier to do the math. that way. But if you want to get specific, now I know with my multiple choice tests and questions, I give you answers that are far enough apart away from each other, generally, especially if it's a mathematical equation. So even if you're using one versus the other, you may notice, okay, well, this is the next closest answer. This is probably one. John may have used 21 or may have used 20 or vice versa. Now, where it matters is what is the FiO2 we're trying to provide. So at FiO2 concentrations of 35% or higher, so all the way up to 100%, it's okay to use 20. It's those very small, low FiO2s where technically we should use 21. Okay, and you'll kind of see it when we start fiddling with some math here in just a minute. Okay, I still say for the vast majority of the FiO2s we're providing, using 20 down here is probably going to be adequate, more than enough. But in case down the road you're solving these and you're going back, wait a minute, the math is off a little bit. If the FiO2 is a low FiO2, like 30% or 28%, 25%, something like that, then probably, to be exact, you should use 21 as opposed to 20. But I'm cool with you guys using 20, okay? I tend to just use 20. It makes my math easier to perform, easier to calculate. But like I said, if you're curious later why your answer may be ever so off from maybe a textbook question or something like that, double check that FiO2. So let's do a couple of examples. So here's the question. Here's the question. This is how the question's going to appear on the test. When's the test?
Wednesday.
Holy crap, Wednesday. Yeah, this Wednesday. All right, the question will be, what is the total flow to a patient if they're on a 40% air entrainment mask, there's AEM, air entrainment mask, with the flow meter running at 12 liters a minute, okay? So they're on 40%, so it's important, you gotta know what the FiO2 is. Because you remember that calculation? 100 minus the FiO2 divided by the FiO2 minus 20. That's gonna get you the air to oxygen entrainment ratio. Then we'll figure out what that entrainment ratio is. We'll add those numbers together and then multiply it by this to come up with total flow. All right, let's do it together. Let's do it together. So again, they're on what FiO2? 40%. So this is what I'm going to set my question up as. So 100 minus that FiO2 minus 20. So 40 from 100 is 60, 20 from 40 is 20, so it's 60 over 20. Divide both of those together, and what am I left with? 3. Now, that 3, always don't forget this, and sometimes folks will get the 3, and they're not sure what to do with it from that point. Our answer here of 3 is always going to be to 1. Okay, we're figuring out a ratio. And what that will tell me, that 3 to 1 ratio will tell me for every 1 liter of oxygen, I'm entraining how much room air? 3 liters of room air. So this to 1 will always be there, meaning for every 1 liter of oxygen, our math is going to tell us, well, how much room air gets mixed in here? All right, for every 1 liter of oxygen, 3 liters of room air gets pulled into the device. Again, I said air entrainment mass, so we're talking about those colored adapters. For every 1 liter of oxygen going through it, it's entraining 3 liters of room air. So a 3 to 1 ratio. That, God bless you, that's the hardest part. That's the hardest part of all of this. That's the hardest part, is coming up with the ratio. Now that I get the ratio, what do I do to the ratio? Add it together. So 3 plus 1 is 4. And I take 4 and multiply that times what the flow meter is running at. So 4 times 12 is 48. There's the total flow of this system. That's the answer to the question, 48 liters per minute. If you wanted to snap a picture of that, just to get the math on the screen with the question, please go ahead. I'll leave it there for a few seconds. Any questions on this particular one? Okay, so on Wednesday when I asked the same question on the test, hint, hint, wink, wink, I'm going to give you a different FiO2. I'm going to give you a different flow meter level running, but the math is still gonna be the same. Okay? It's to figure out, the answer is gonna be to 1. For every 1 liter of oxygen, how much room air is this device in training? Was there a question?
And then if it was 20%, it would be minus 21 instead of,
If the FiO2 was less than 35%, 30%, let's just say, pluck a number out of the air, 30%, then technically I should use 21 here, but you can see how kind of clumsy the numbering gets, and we're gonna end up with answers in the points,
right,
okay? So I'm fine with you guys using 20 here. It's gonna make our math be a little bit simpler, a little easier.
So it's 48 liters of,
Total flow going to the patient.
it's the combined.
Correct.
Room air coming in the device and from the flow meter.
Correct. Because how much flow is coming from the flow meter? 12 liters, so 12 liters of oxygen. Three times that is the room air that's coming in. That's why I just say add them together so we can get the total flow going to the patient. Now, I have a couple more examples just for us to practice with. The next one, now they're on a 60% device, so 60% aerosol mass, and this time the flow meter is running at 10 liters per minute. So again, figure out the air to oxygen entrainment ratio first. Again, 100 minus the FiO2, 60, divided by 60 minus 20. So 60 from 100 should be 40, 20 from 60 is 40, right? So 40 over 40. And that equals what? 1. So for every 1 liter of oxygen, this device is pulling in 1 liter of room air. For every 1 liter of oxygen coming from that flow meter, this device on 60% is pulling in 1 liter of room air. So what's the total flow of this particular system? 20 liters per minute. Okay, so add them together. 1 plus 1 is 2. 2 times the flow meter, 20 liters per minute. Anybody want a picture of that one before I change it? I got one more example, and then we'll move on to something different.
I feel like the next one's gonna be a tricky one.
It can be a tricky one. That's why I picked it. All right, the next one. Now they're on 80%. FiO2 is 80%, and the flow meter is running at 15 liters. All right, they're on 80% oxygen. Flow meter's running at 15 liters. I'll shut up for just a minute and let you guys figure out the math, and we'll do it together. Somebody come up with a number. Okay, we'll do it together now. So again, the FiO2 is 80. So my math here is going to be 100 minus 80 over 80 minus 20. What does this give us? 20 over 60. All right, 20 over 60. So that means for every 1 liter of oxygen, how many liters of room air am I in training? 0.3. 0.3. I've had students before sit there and look at this kind of backwards and go, oh, that's 3 to 1. No, it's not. 40% is 3 to 1. 80% is 0.3 to 1. Meaning for every 1 liter of oxygen, how much room air are you pulling in? Only 0.3 liters of room air. Which if you think about it, that makes sense. Your device is trying to provide 80% oxygen, so you should be pulling in a lot more oxygen than you, and very little room air. Okay, but the question asks, what's the total flow? So what do you do to the 0.3 to 1, excuse me, ratio?
Add those.
Add them together. So it's 1.3 times 15. And there's your total flow of only 19.5 liters. What do you think? Is this going to be a high flow device? It's only providing 19.5 liters. That's not a lot of flow, total flow going to the patient. When we said originally, high flow device should provide 60 to be safe. Okay, we're only providing 19.5 liters of total flow going to the patient. And if you notice, the FiO2s I've given you, I've changed the flow meters just to have a different number here, but the FiO2s, the higher up on the FiO2 we go, what seems to keep happening to our total flow? It goes down. Who needs higher FiO2s? What sort of patients need higher FiO2s? The same. The two specific. Right. Who needs higher FiO2s? Sicker patients, right? Sicker patients need higher oxygen concentrations. And what's happening to the total flow we're giving them? We're providing them less. We're probably converting what's supposed to be a high flow device into a low flow device. Is the patient really going to get that FiO2? Probably not. Not if we're able to give them, if we're not able to give them enough flow. So that's always an interesting concept to think about when you have a patient that does need higher oxygen concentrations and you're providing less flow going to the system or to the system. How can you increase the total flow here? How can I make this flow higher?
Provide a lower FiO2.
And not change their FiO2, because this patient we have today is really, really sick. They need that much oxygen. You know, higher liter flows, higher liter flows. Now we'll get into some of those limitations later, because there are certain flow meters that only go up to a maximum of 15 liters. But they do make other flow meters that can go much higher. So that's always something to consider as well. All right. Is this calculation completely ridiculous? It's not that bad. Will you have to do it often? Probably not. Like I said, at the bedside, visually, how do I know if I'm providing enough flow? I notice that mist doesn't completely disappear when the patient inspires. If the mist is still present, patient, some of that mist does go away as the patient is inspiring, but it doesn't completely disappear. Speaking of flow, your device has provided enough flow. So there's no reason to do this math. Now I can't help you when the NBRC asks you to give them a number, or Wednesday when I ask you to give me a number, you're still gonna have to do the calculation. But another thing, and for what it's worth, those ratios do not change. The ratios do not change. An FiO2 of 40% is always 3 to 1. It's never going to change. An FiO2 of 60% is always 1 to 1. It doesn't change. An FiO2 of 80% is always 0.3 to 1. It doesn't change. So I've had some people go, John, I'm just going to memorize this chart. More power to you, because there's already a lot up here that we have to memorize, right? This is just something to add into the mix. And let me also throw this in. It doesn't give you a range for, say, 55% or 65% or 75% or 90%. But knowing that mathematical equation, it doesn't matter what FiO2 it is, you can still calculate it. But you'll hear me say this down the road with you guys when we're reviewing, practicing for board exams. The FiO2 the NBRC likes to use, 40%. Probably the second most common one they like to ask is 80%, because they know that when people get flip-flopped, get backwards. So if these are the ratios, again, we've already done 80%, we've already done 60%, we already did 40% in the calculation. we could sit there and do some of these others. When you get to those lower FiO2s, again, remember that formula. You should probably choose 21 if you want your answer to look like the charts. But when, for example, when we did 80% and we added them together, 1.3 times whatever our flow meter was running. If it was 40%, 3 to 1, that's 4 times whatever the flow meter was running to get the total flow. But if you notice, the higher the FiO2, the less room air gets entrained, more of your source gas, which again is going to ultimately lower the total flow. Look, if I have the FiO2 really, really low, 24% at its lowest. That's an air to oxygen entrainment ratio of 25 to 1. For every 1 liter of oxygen, this device will pull in 25 liters of room air. That's why when you turn those air entrainment adapters, why it gets so loud and noisy on the lower FiO2s, because you're sucking in so much room air to the system. That's why it's so loud. When you close those air entrainment ports and you're giving more of your source gas, why it starts to get quieter, just by comparison. You may still hear it, obviously, but it's not going to be as loud at these higher FiO2s as it is with the lower FiO2s. Again, because you're pulling in lots of room air with the device. Okay? All right, so still with these air entrainment systems, problems with downstream resistance with these systems. So any increase in flow resistance downstream or distal to the point of the air entrainment, and I don't care whether this is an air entrainment mask or an air entrainment nebulizer, air entrainment system, they can all be affected by downstream resistance. So increased downstream resistance causes back pressure. Back pressure back to the air entrainment ports. It will decrease how much air gets entrained into those air entrainment ports. Meaning if you're entraining less room air, what are you going to give more of? Your source gas, which is oxygen. And so your FiO2s will increase going through the device. Less room air being entrained means what's happening to total flow? Less total flow going to the patient. And again, it could be the concept of I just made a high flow device and unintentionally I turned it into a low flow device because of downstream resistance. Now, one of the reasons for downstream resistance would be water in the circuit. Now you see that with the trach collar, aerosol mask, face tent, or T-piece. Again, we talked about this before. When you set up that system, large volume nebulizer, corrugated tubing, what's the thing we always have to have in the middle? A drainage bag, right? A drainage bag to catch any condensation so there is no water left in the circuit. If we were to forget the drainage bag and now there's water left in the circuit, as that water level increases, more back pressure is going to go back to the air entrainment ports and cause what to happen? Less room air to get pulled in, meaning you're giving more of your source gas, which is oxygen. A similar situation can occur with an air entrainment mask, Venturi mask, if those air entrainment ports on that colored adapter are blocked. You're going to have patients, you're going to walk into a room, patients wearing a V mask, a Venturi mask, and I should have brought a mask in with me, but as that corrugated tubing goes down to where that colored adapter is, approximately what location is it? It's right here. I've walked into patients' rooms and they have it held right here. The straps are on, you don't have to hold the Venturi mask, but they're holding it right here. Where the colored adapters are, they're holding it right here. What are they preventing from going in? Less room air, more source gas. Here I can see a hypothetical MBRC question in your future where you have a patient who's on a Venturi mask who was alert 5-10 minutes ago, becoming very sleepy and lethargic. Oh, I forgot to mention, they have COPD. They're becoming lethargic. What are they doing with their hand, blocking those air entrainment ports? You think you've given them 28% oxygen, but now that those entrainment ports are blocked and they can't pull in room air, what are they receiving? More of the oxygen, so their FiO2 coming from the device is actually going to be higher. And no wonder they're sleepy and lethargic. You've knocked out their drive to breathe by giving them a higher FiO2 than what you intended. And that was no fault of yours, it was the patient holding that. Or, you know, I always pick on grandma. Grandma's always freezing, right? She has all the blankets pulled up to her chin. She has a Venturi mask on. Where's their entrainment ports? Under all those heavy blankets, causing less room air to get pulled in. So that still is a common occurrence with an air entrainment mask or Venturi mask type system, just to the location where those air entrainment ports are. All right, the high flow nasal cannula. So as opposed to the standard nasal cannula that we talked about last week, the low flow nasal cannula, this is the high flow nasal cannula. A cannula that can provide high flows, significantly high flows. When you talk about your standard nasal cannula, what's the liter flow for an adult?
2 to 6, 1 to 6.
1 to 6 liters a minute for an adult. And has anybody had an opportunity to ever actually put on a nasal cannula and feel the flow? And felt the flow? Did you turn it up to 1 or 2 liters? Did you crank it up to 4 or 5 or 6 liters? How'd you like that? Not at all. It's a lot of flow for a standard nasal cannula. For me, at 2 liters, it's irritating. Makes my nose itch. I want to start sneezing. You increase that flow higher and you haven't added a bubble humidifier, it's even worse. My eyes will start watering. That's why, again, at 4 liters plus, please put on a bubble humidifier. With a high flow cannula, however, you can provide flows of 20 liters, 30 liters, 40 liters, 50, 60 liters on up via nasal prongs, just like your standard nasal cannula. And the patient will accept it and will tolerate it and say thank you very much. And they will not feel uncomfortable. They will not feel like their nose is about to explode with irritation, all simply because we've added what to this system? Heat and humidity. Heat and humidity. These things can be warmed, temperature controlled, so I can provide plenty of moisture to the patient, and it's that moisture that makes it comfortable for the patient. When these things first came out, and they've been around for a long, long time. There was some problems in the very beginning with high flow cannulas. It was a cleanliness issue, so it's probably set this industry back probably a good 10 years. But it's back again, and it's coming back with a vengeance, and I think all in a positive light. When these things first came out, I was at a respiratory conference trade show, and actually a friend of mine who worked for one of the companies that makes one of these things says, "John, have you seen this?" And I said, "I've heard about them, but at that time I'd never seen one before." He goes, "Well, here." He gave me the cannula. He had me put it on. He connected me to the system that they had. Now, everything was kind of behind the table, so I couldn't see what he was doing. And he goes, "How does that feel?" And I said, "It feels fine." He said, "Would you believe you're at 40 liters right now?" And I said, "There's no way." And he said, "Come back here and take a look." I was at 40 liters. I was perfectly comfortable, perfectly content, wasn't bothering me one bit. He said, "Okay, I'm going to increase the flow. Tell me how you feel." I'm like, "Okay, I can tell you're increasing the flow going through there, but it's not uncomfortable. It's not intolerable. It was fine." He said, "What about now?" He brought me up to 60 liters. And I said, I can definitely feel it. And I'm not going to use the word, it's not uncomfortable. It definitely doesn't hurt. But I noticed when I exhaled, I could feel resistance. I could feel pressure that I was trying to exhale against. He said, "Okay, when your patient feels that, you kind of know you're at the maximum inspiratory flow that is necessary for them. They should feel a little bit of back pressure, a little bit of resistance, but it should not be uncomfortable for them to exhale. If it is, then the flow is too high." But I was amazed at the time going, "Wow, this is really comfortable." And again, what FiO2s could I receive with one of these devices? It could be a very low FiO2, 22, 23%. I mean, really nothing. I asked the question, why am I even on oxygen if I only need that low of an FiO2, up to 100%, and any FiO2 in between, and all given via a nasal cannula type device, nasal prong. So you mean if I needed 100% oxygen or 80% oxygen, I don't need a mask? I don't need any sort of mask type system and being all uncomfortable and claustrophobic perhaps with a mask in my face? No. You can achieve everything you need FiO2 wise and flow wise with a high flow nasal cannula. So I said right there, the rest of those O2 devices, see ya, sayonara, not necessary anymore, right? Of course, they're still around. The other devices are still around. These things are expensive by comparison, so it's not going to replace everything that we have, but it's a wonderful, amazing device. It is more expensive. There are more parts and pieces, of course, than just say a standard nasal cannula. So, but if my patient needs it, my patient needed this device, we have the capabilities to provide it. So high flow nasal cannulas do require a patient interface, these special nasal prongs, but they do even make them where they could be attached to a tracheostomy. Again, providing high flow for a tracheostomy patient. A gas delivery device that regulates the FiO2, so maybe some sort of blender type system to give a precise FiO2, and a humidifier with moisture, of course. That's going to keep this system comfortable and tolerable for a patient. The air oxygen blender system capable of providing 60 liters a minute of flow going to the patient. Now, this is probably a more current appearing type device. Airvo is a brand name. It's by a company known as Fisher-Paykel. They're the humidifier company, but they do provide high flow nasal cannula systems. Now, the system itself, so there's really the heated Passover humidifier we can use with a ventilator patient. It's the same type of device, but with this apparatus that is connected to a oxygen flow meter, so small bore tubing that goes down, you can't really see it, that ends up hooking in the back end of the device. So you're still turning on flow here, so there's your oxygen. You do have a bag that's providing moisture to your humidifier. You do have special tubing, again, that's larger tubing, but special tubing going to the patient interface. Again, the interface matches the high flow cannula system, so you can't mix and match all of these. They do need to be from that same company. But on the back of the device, so it's kind of back over on this side, there's your oxygen tubing going into the system, and room air gets pulled in through the back. So it does mix oxygen and room air into the system to give a very specific, precise FiO2 to our patient. There's some controls on the top, but we're not going to worry about that just yet. You'll see that more with Desmond when you're in the lab with him. But can provide plenty of flow, plenty of oxygen, and all through a simple nasal cannula type interface. There's all kinds of applications for this type of system when you need someone to receive a higher FiO2 and you're having trouble finding just the right device that's capable of doing it. Again, this should be the go-to. Now, I will say it's expensive by comparison of our other devices, so when you're in your travels and clinicals, and you may have seen something like this or some of these high-flow cannulas in the equipment room, in the supply room, good question to ask, how many high-flow cannulas do you guys have? You know, the devices, not necessarily specific, just the cannula, but the whole system. How many of these systems do you have? You know, if the hospital said 5, 10, I get it, that's not much. You know, if they said 20, 30, okay, that's better, but that's not going to be able to support every single patient in a 500-600 bed hospital that needs oxygen, right? Again, you have to use them for the right patient at the right time. Again, I know when these things first came out, we only had a handful of them, and we showed the physicians, the docs liked them, and the docs would start ordering them, and then we had to say, hold on, we don't have that many. You know, it needs to be the right patient that really needs it. That patient should take priority and receive it. Our hospitals have more of them now, but it's just not an unlimited supply of high-flow nasal cannulas. So that could be a limitation when you're out there going, why don't we just try a high-flow cannula? That'd be nice, but everyone we have is up in use right now. So again, something to consider. Now, 4 main features of a high-flow nasal cannula: can deliver a high FiO2, up to 100% if necessary. Meets or exceeds the patient's inspiratory flow needs, makes it a high-flow device, and provides a fixed FiO2. So an FiO2 that will not change, will not vary. Number 3, remember I said if the flow is high enough, when the patient exhales, they will feel a little back pressure or resistance they're exhaling against. That's what number 3 is saying. Generates a distending positive airway pressure. it functions a lot like CPAP. It functions a lot like CPAP. Now, I'm being careful in how I say this. A high-flow nasal cannula device does not provide CPAP, but it functions like CPAP pressure would. Right now, we can't claim it as CPAP therapy because number one, there's no way to know what the pressure the device is providing. So I can't call it CPAP when, I mean, is this patient on a 5 of CPAP or 10 of CPAP or 6 of CPAP? I don't know, I can't measure it yet. The technology's not there yet to tell me what the pressure is. Now, one day will there be? I'm sure there will, and that'll be great. There is a guesstimate. It's estimated that for every 10 liters of flow, you're providing about 1 centimeter of water pressure. So if you're providing, say, 50 liters of flow, that's probably equates to 5 centimeters of water pressure, 5 centimeters of CPAP. But again, there's no way to measure that. The other concept is that's fine if it's providing all of this flow, which translates to pressure like CPAP. But what happens the second the patient opens their mouth? What happens to all that pressure? Right back out. And so, again, we can't call it CPAP, but it's, lack of a better word, CPAP-like. CPAP-like, right? It can be, again, you can provide pressure with it, and that's why we see such success with these devices, because we're providing some degree of pressure for the patient to exhale against. Number 4 here, washes out carbon dioxide from our own anatomical dead space. You just exhaled, right? Some of what you exhaled was dead space, was rich in carbon dioxide. You didn't exhale it all out. Next breath you take in, you're gonna have to overcome some of that dead space, God bless you. But if the high flow nasal cannula can flush out, wash out all of that exhaled CO2, well, what's left in its place instead of carbon dioxide? It's oxygen. And so no wonder my patients' O2 saturations tend to go up, especially those more difficult to saturate or to oxygenate patients.
So you said that this needs to kind of go to like a special patient. So would you consider like emphysema or COPD, somebody with a lot of like stale air? This would be something that
Potentially,
would be positive for them.
potentially. Without getting into a specific illness or disease, I'll use this. I have a patient over here that I can oxygenate them with a standard 2-liter nasal cannula. Okay, I could probably do the same thing with this, but no, standard 2-liter nasal cannula does it. This other patient, we tried 2-liter standard nasal cannula. Their O2 sats are still low. I increased the flow. O2 stats remain low. I've switched them to a Venturi mask. O2 stats still remain low. I've tried different things without success. Let's try this one. Maybe that's the special patient I'm referring to that would benefit best from this, as opposed to the other patient that's wearing a 2-liter cannula and I'm successful, their O2 sats are now fine with it, fine. That device works for them. And that Venturi mask works for that other patient. This other patient, we've tried some of that stuff, it's not working. But we tried to this, we went to this instead. Now we're seeing success. So that's as opposed to picking a specific disease entity. It could be any disease entity, but patients who were having trouble oxygenating.
Right now, we just do that because of availability, because it's not, you know.
Right.
'Cause if we could, if it's
If I-
endless, we just go with
If
it.
I had an unlimited supply of these, and my boss didn't care that we used them on every single patient, I would say, I would select this for every single patient, right? Low FiO2s for most, because most of us don't need a high FiO2. The sicker patients are probably gonna need a higher FiO2. I say too with this, and again, without getting too much into end-of-life care, that sort of concept, but when we have patients that are not long on this earth, right? Palliative care, hospice care, and I'm trying to, again, just because they're maybe a DNR, palliative care, hospice care patient, doesn't mean we're not gonna treat them. Doesn't mean we're not gonna do anything for them. The only things we're not gonna do is anything heroic, like chest compressions, intubation, mechanical ventilation. Those things we're not gonna do for a patient who's a DNR. This is a patient that wants to be kept comfortable, nature will take its course, you know, that sort of thing. They're spending time with their family, whether it's going to happen today or next week or next month, we don't know. But I don't want that patient to be breathless, right? I don't want that patient to have a low sat. I don't want that patient to feel short of breath. What we typically would do, or we would get to the point that, well, boy, this patient's really not long, but they're still alert, they're still awake. Let's give them more oxygen. Okay, here's the non-rebreather. Has anybody seen a non-rebreather actually on and running? How loud it is? You have all this flow going to the patient's bag, right? The mask on the face. They can talk, but it's very muffled, you can't hear. You know, how much communication between the patient and their loved ones? Again, remember, this is going to be their final hours, minutes, days, you know, on this earth. So what ends up happening is family they're at the bedside and, you know, spending time, but as far as any discussions, the family's afraid to talk to the patient and all this loud noise. The patient, if they attempt to talk, it's all muffled, you can't hear them anyways. This in end-of-life care is amazing because it's quiet. It's like a nasal cannula. The patient can, again, if the patient's capable, can still talk and communicate. The family doesn't feel as, they don't feel like they can't talk to the patient, as opposed to the big mask roaring. I say it's a hurricane in their face with that non-rebreather. You know, we can have something set up like this. Again, making those final days, minutes, hours, days, weeks even, a better experience for the patient and their family, their loved ones. That's my 2 cents, and I don't want to get too much into that topic today. That's a whole other topic for another day. But any questions about the high flow cannula? It is the future. It keeps evolving and evolving and evolving. We're getting better devices. In the original, we didn't make our own per se. We needed some things from our department that we could build. We kind of did make our own to a certain extent, high flow cannulas. Like I said, the original company that came out with these, there was some cleaning issues that we were supposed to do, that we followed the manufacturer's instructions specifically as it was written. Found out later, it didn't do as good of a job as they claimed, so that really set, and so the physicians, guess what they did? We're not ordering this. We heard about the infection risk with those original ones. So it did set back this industry about a decade, about 10 years worth. But it's back and it's moving forward. We don't have those issues like we had with the original versions anymore. But it's great. It's amazing.
Could you use this as like a once in a while treatment to wash out all the CO2 for certain patients?
And you mean as a treatment, like a 10-minute, 15-minute treatment?
Something like that?
Nothing that short, because, okay, that may work during the 10 or 15 minutes, but what's going to immediately return the second you take them off of it? CO2 is going to come back in there. So if we need it for that purpose, then let's leave them on it. Let's provide the high flow. Let's wash out that CO2. Again, replacing their exhaled CO2 with oxygen that's ready for them to pull in until they're stronger, until their situation's better. You know, the disease process is reversing. Whatever's causing us to use this in the first place has gotten better. So I wouldn't say necessarily as a short-term treatment, but if they need it for the next 24, 48 hours, next week, you know, if they're that sick, then, you know, absolutely, we'll use it. Does the patient need to be in the ICU on one of these things? No, they could be on the floor, which is great. When we talk about ventilator patients, that has to be in the ICU. BiPAP, non-invasive ventilation, for those critical care patients, they have to be in an ICU. This could be the patient, again, how many ICU rooms do we have? There's not an unlimited supply, and who gets the ICU room? The most critical patient. And there's times that, okay, we're gonna send this patient back out to the floor because this other patient's much more critical now. But maybe if we had the room, we would have kept that patient in the ICU for a little bit longer, another day at least, before we move them out. So these things are great because they can be in a standard regular patient room. Again, as long as I have the gas source. All right, blending system. So here's another system. If we weren't capable of using some sort of air mix type system, the air entrainment type system, we can use a blender. Blenders actually mix in oxygen and room air to give whatever FiO2 we want. And so they can provide these. And again, we call them blenders, air oxygen blenders. If you were to look inside of these things, and this is a picture from the textbook, it's connected to both compressed oxygen and compressed air. Again, so one of those DISS quick connects, that was from some chapter we're going to talk about soon, wasn't it? All right, so the DISS, diameter index safety system, those quick connects of oxygen and air. Oxygen and air come in here, it mixes depending on how I've set the FiO2 to provide that FiO2 to the patient. Now here's a troubleshooting question or troubleshooting concept. These things, I'll even bounce back picture. These things, even though it's not digital, does have an alarm. If a blender alarms, if an air oxygen blender alarms, it means something's wrong with the oxygen or oxygen pressure or the air or air pressure. Now I've seen this happen to students before. You plug in one and you should hear it click. I mean, it's caught. The other one, you think you put it in there, you put your hand away, oh, it's still sitting in there, but it didn't click. This thing starts alarming. You call me, John, the blender's alarming, I don't know what's wrong. Check your connections. Make sure you're completely plugged into both oxygen and air. Because if neither one is connected properly, the blender will alarm. All right, the chapter does mention other oxygen delivery devices. Yeah, I guess a bag mask system is technically a delivery device. Again, if set up properly, connected properly to oxygen, it is going to provide 100%. These self-inflating bags, if you didn't even connect them, because I think in the lab when we practice generally, especially we're not plugging them into oxygen because I don't want to waste the O2 because we typically turn the flow meter so high. But even when you guys were practicing intubation, right? We never plugged those things in any gas source, did we? No. Whether it was oxygen or air, we didn't plug those things in. But when you squeeze the bag and you let it go, what happened to that bag? It was self-inflating. So these self-inflating bags. So when we were doing intubation lab that day, what FiO2 were we providing every time we squeezed that bag? Well, 21% because we weren't plugged into oxygen. We get plugged into oxygen, then there's our 100% O2. And again, it will self-inflate. If set up properly, it should self-inflate every time you squeeze that bag and release, it will self-inflate. But again, self-inflating bags that are capable of providing 100% O2. If I bag a patient like this, am I giving that bag time to refill? No. What happens to my FiO2 if I'm not allowing time for that bag to refill? FiO2 is going to be a lot lower. So remember that when you're resuscitating a patient, bagging a patient, you don't have to squeeze the bag like this. If I'm squeezing like this, that means I'm giving one breath every second. That's a respiratory rate of 60, right? There's no reason to ventilate somebody at a respiratory rate of 60 when you and I breathe normally at a respiratory rate of 12 to 20. That's why we should wait. Again, if the patient's not breathing, squeeze the bag, wait 3 to 5 seconds, and then I'll squeeze the bag again. Now, the only time I change that is if the patient's breathing, then I want to breathe with them. And that definitely is more challenging for us because we're really having to keep our eyes on the patient's chest rise and fall to make sure I'm timing it just correctly when the patient's attempting to take a breath in. All right, I don't believe I've talked about these with you guys before. I don't remember if we've had this conversation or if I'm confusing you guys with the second year students, but demand flow or pulse dose systems, these are special systems that can be attached to an oxygen cylinder that provide oxygen only during inspiration. It's the oxygen version of a band neb, right? Can be set up to provide oxygen only when the patient inspires. So if you think about traditionally, not this system, traditionally, patient with an oxygen tank, you turn it to 2 liters. That's continuous, 2 liters constantly flowing out of that tank. You connect the patient's nasal cannula to it. It's 2 liters, it's constantly flowing through. The patient inspires, they inspire the O2, they exhale, O2 is still freely flowing. Even when they're exhaling or they're waiting a few seconds before they take their next breath in. That's continuous flow. That's how it typically works. These devices can be set up to sense when the patient is inspiring, and it will only give the breath when the patient is inspiring. So guess what happens with the oxygen? It's going to last longer because it's only going in during inspiration. Don't see that in the hospital setting, but more in the home care world, you can see something like this as a means to not go through the O2 so quickly. I laugh when I say this. I had taken my father to a doctor's appointment one day, and we're sitting in the waiting room. Now my back's to the door. Father's sitting next to me, but my back's to the door, and somebody came into the office, and I can hear, psst, psst, psst. The person was sitting right behind me, and I'm like, oh man, I need some respiratory students here to be able to show them this device. The psst that I was hearing was the patient inspiring, and there goes the oxygen. I sat there with never even turning around looking at the patient. I counted the respiratory rate because I'm a dork like that. Counted the respiratory rate because I could hear every time they took a breath in because I'd hear the psst of the gas. Only going during inspiration. Now these things can be set up. I know you can't really see the picture. There's off, there's the different liter flows, but there's also a CF. This does not mean cystic fibrosis patient. That means continuous flow. So think about the patient, and my example, that patient that came in the doctor's office, and I didn't know who that individual is, but maybe when they exert themselves, like walking from the car into the doctor's office, exerting themselves, they need a little bit more O2, they could turn it to continuous flow. Do whatever they need to do. Maybe they need to walk into the doctor's office, but once they're sitting down and resting, not as winded anymore, they could turn it back to the pulse dose or demand only setting. So something like that does exist. Now, other medical gas therapies, this kind of ends the chapter here. Hyperbaric oxygen therapy, I know we talked a little bit about that in the past. So this is providing oxygen at pressures greater than normal atmospheric pressures. Now, right now at sea level, normal atmospheric, we call that 1 atmosphere. But we can actually increase the atmospheres to 2 or 3 times typically for a treatment. They can go even higher than that, but typical treatments are 2 to 3 atmospheres. Meaning, what's our barometric pressure here right now?
760.
760. If we go 2 atmospheres, double that 760. If you go 3 atmospheres, triple that 760. It's the exact opposite effect as going up in elevation, where the air's thinner, barometric pressure is lower. We're actually like we're submerging them down. Anybody that's ever dove or swam in a pool that's very deep, what do you feel in your ears? You feel that pressure again, and that's only in a 8, 10, 12 foot pool, depending on how deep the pool is, how much pressure that is. So yes, we're increasing the pressure. So if the patient's just on 21% oxygen, what do we say, how much oxygen in this room in millimeters of mercury? 21% times 760. Well, what if you doubled or tripled that 760 and still 21% times that new number? It's providing much more oxygen to the patient. Now, is it going to make more oxygen hop on board the hemoglobin? Let's say you walk in there, your saturation is 100%. Every one of your hemoglobin is carrying the 4 molecules of oxygen that it's supposed to. This does not suddenly add a 5th seat, right? Nobody's sitting on anybody's lap on the hemoglobin, right? So it doesn't increase the oxygen on the hemoglobin, but it increases the oxygen dissolved in the blood plasma. That normal thing that's only about 2% of our total, it can significantly increase the amount of oxygen dissolved in the blood plasma, and now really make a huge difference in how much oxygen is actually in the bloodstream. Doesn't increase the amount on the hemoglobin, but it definitely increases the amount of oxygen dissolved in blood plasma. So what can it do? It can utilize Boyle's law. Oh crap. What was Boyle's law? What's constant in Boyle's law? Pressure. Remember bat? Temperature. It's the temperature that remains constant. Meaning pressure and volume vary inversely. So if the pressure goes up because they're in a hyperbaric chamber, what happens to the volume, and specifically volume and air bubbles in the bloodstream? Now divers could get this if they ascend to the surface too quickly and get nitrogen bubbles in their bloodstream. So to eliminate that, they could be in a hyperbaric chamber. That's going to help remove the nitrogen from those air bubbles in their bloodstream. Hyperoxia means high, significantly higher amounts of oxygen, meaning hyperoxygenation of blood and tissue. Again, if the body needs increased oxygen, somebody could say, well, yeah, John, but ototoxicity and all that stuff, yeah, I agree, that's still a concern, but maybe some tissue or some organ needs increased amounts of oxygen. It can cause generalized vasoconstriction. So blood vessels can vasoconstrict, which can lessen tissue edema and swelling. This part is an interesting neovascularization, the formation of new blood vessels. So and I think I'll talk about it in just a second, but if we have patients who have wounds that won't heal because they're not getting adequate amounts of blood to the tissue, to the skin to heal, if it causes the formation of new capillary beds and new blood vessels, it could help to increase blood and oxygen getting to those tissues, which in turn can help with wound healing. Our diabetic patients that have peripheral vascular disease, they can't get blood flow to the extremities. That's why we see diabetic patients that have to have a toe amputated, or a foot amputated, or a leg amputated, because they're just not getting good blood flow. Hyperbaric therapy. Two different types of chambers for hyperbaric therapy. A multi-place chamber where multiple patients could be inside all at the same time, or a single monoplace chamber where just an individual patient's in. Again, I've said this to you guys before. I'm not a claustrophobic person, but you put me in one of these things that's like coffin-like, but with plexiglass, so I can still see the outside. I just know myself. Again, I don't think I'm claustrophobic, but that may give me a pause. You know, and when they're in here, they're not in here for 5-10 minutes. They could be in here for a few hours. So it's one of those things. All right, breathe through it. Breathe through it. Calm down. Maybe I need a pill before I get in there. You know, something like that. But we can put oxygen on a patient. So not only, you know, if I put them in there with no additional oxygen, well, 21% of that new pressure. But if I give them oxygen, now it's that new FiO2 at that much higher pressure. Again, significantly increasing the oxygen in the bloodstream. These are just a few examples. There's a lot more than this, but some of these, decompression sickness, that's the diver that's ascends to the surface too quick and get nitrogen bubbles in the bloodstream. That's one. Air or gas embolism, carbon monoxide poisoning, again, helps to significantly reduce the half-life of carbon monoxide. Clostridial gangrene that causes gas gangrene. This is a significant bacterial infection that leads to toxins that release gases. Necrotizing soft tissue infections, again, wounds that won't heal. See that with the diabetic patients, and again, they would be more under that chronic type condition. Athletes use hyperbaric therapy to speed the recovery process. It's been a while, but I know the Jags had a hyperbaric chamber inside of their facility, again, where their athletes can get in to speed up the healing process. I know I date myself now when I say it, but does anybody remember when Jacksonville hosted the Super Bowl? Crickets. It wasn't that long ago, damn it. All right, when Jacksonville hosted the Super Bowl, it was the New England Patriots and the Philadelphia Eagles. Desmond will be happy I'm mentioning the Eagles here. But one of their star wide receivers, Terrell Owens, had a high ankle injury like 2 or 3 weeks before the Super Bowl. He missed a few games, but by God, he said, I am playing in that Super Bowl. But he had a high ankle injury. He spent so much of his therapy treatment time in a hyperbaric chamber. He actually played in that Super Bowl and did very well. Eagles didn't win that Super Bowl, but he played very well, considering he was, again, a wide receiver who's running around, cutting and stuff like that on a bum ankle. He still had an amazing game. And I'm dating myself here. Michael Jackson, some of the wounds and things, the nose that wouldn't heal. If anybody remembers Michael kind of toward his later years, he had a hyperbaric chamber. Now for him, I'm not sure what good that did because he kept having surgeries, but that was something that he was using and utilizing, hyperbaric oxygen therapy. If you encounter any places in town, wound care centers, I bet you they have hyperbaric chambers inside their facilities. Again, for the wound healing, the neo-revascularization, the increased blood vessels seen with hyperbaric oxygen therapy. All right, even though the benefits can be significant, it also carries significant risks. Ear or sinus trauma are probably the greatest, most common issues. Again, I use the diving down in the pool analogy and the pressure you feel in your ears. You would feel the same thing inside a hyperbaric chamber. It could even be to the point of tympanic membrane rupturing of the eardrum. It can cause alveolar overdistension, a pneumothorax, O2 toxicity from the hyperoxia environment, fire, and then my personal favorite, claustrophobia, because I think that would probably start happening to me. You can see here, these are two multi-place chambers where multiple patients can all be in there at the same time. I don't know if you can really see, it looks like they're all going to outer space, right? Or going down in a submarine. Again, different FiO2s can be provided for each patient as they spend time in there in the chamber. Again, this is what one would look like from the outside. Again, staff do go inside with the patient. Again, it's like a submarine. There's this wheel to turn around and open to let them get in. There is an ante-room that they go into first. The outer door gets shut, then the inner door opens to allow them access into the chamber. Again, this is the thing I told you guys before. If you were able to study inside this hyper-oxygenated environment, would you retain more? Would you remember more? I think you would, but that's just my 2 cents. All right, nitric oxide therapy, inhaled nitric oxide therapy that did appear in one of the earlier chapters, is a very selective pulmonary vasodilator. So it dilates blood vessels, but specifically the blood vessels that are in the lung. As opposed to, say, someone who takes nitroglycerin, sublingual nitroglycerin, they place it under their tongue. You know, somebody with angina, chest pain, that sort of thing. They take one of those, they're always told to sit down because nitroglycerin is a potent systemic vasodilator. It'll vasodilate everything, so their blood pressure can suddenly kind of bottom out. That's why we tell them to sit down when you take it, in case it was to happen. This is unique because it doesn't dilate everything, it just dilates the pulmonary vasculature. And again, I used this before, indicated for term or near-term infants with hypoxemic respiratory failure and persistent pulmonary hypertension. Hypertension meaning high blood pressure, but pulmonary hypertension. Adult studies of inhaled nitric oxide are inconsistent. I think one day it will have a place, one day, but right now the literature and all the studies have shown there's really no improvement in morbidity or mortality on any adult receiving this. And for what it's worth, I think by the time we try this on a patient, their disease process is already pretty advanced, pretty severe. The patient probably wasn't going to survive anyways. And so when we try this, notice I use the word try, we try this, what's the patient outcome? They still die. Okay, so that's where I think some of the literature and the studies go, well, look at all these low, poor outcomes. The patient was probably going to have a poor outcome anyways. We tried this, and now this gets tied to that poor outcome. So there's a place for this. Not every single person's going to need it, but again, more studies, more things have to be done with inhaled nitric oxide. And again, in case you're curious, that's why it's not FDA approved to be used on adults, because nothing in the literature says it improves outcomes. The literature says it doesn't. It doesn't show anything right now. Benefits: improves blood flow, again, because it dilates the blood vessels, but only to ventilated alveoli. If you have a bunch of alveoli that are collapsed, well then those blood vessels are not going to receive inhaled nitric oxide. We have to have ventilated alveoli. Where the ventilated alveoli are, that's where we'll see the blood vessels dilate. Helps to reduce shunting, improves oxygenation. That's probably the biggest thing. It helps the patient oxygenate better and decreases the resistance going through the pulmonary vasculature or pulmonary blood vessels. Recommended initial starting dose is 20 parts per million. That ppm, parts per million, 20 parts per million is the initial starting dose. And then it could be adjusted accordingly. Heliox, I know we talked about Heliox already. Again, Heliox, we use Heliox because it's we use the helium of the Heliox. Heliox is a mixture of helium and oxygen. We use the helium part because it's so light, and we use it so we can deliver that oxygen past some sort of obstruction, some sort of narrow airway where oxygen typically couldn't pass. So we can use Heliox. Again, Heliox, and I said this before, does nothing for the obstruction. It's simply a way to get oxygen past the obstruction and get that oxygen down to the alveoli. Typical doses are a 80-20 or 70-30 mixture. Remember, the higher number is helium. The lower the number is oxygen. So an 80-20 mixture is 80% helium, only 20% oxygen. But still, it's amazing when you see somebody improve with that, and basically you're giving them room air, but you're able to actually get the oxygen down past the obstruction. Should be delivered. So Heliox needs to be delivered in some sort of closed type system. Again, if I delivered it, say, with a standard regular nasal cannula, because the gas is so light, it'd probably leave before the patient could inspire it. So closed system like a non-rebreather, and I like it because it has 3 one-way valves, but a non-rebreather. It could even be on a high-flow cannula. High-flow cannula is an exception to the standard cannula. Again, can provide that to a patient. Certain brands of mechanical ventilators are capable. Not every, so I'll say a mechanical ventilator, you can deliver Heliox through a mechanical ventilator, but now I would look at the brand of that ventilator because some are not able to deliver Heliox. So when it comes down to it, push comes to shove sometimes, and our departments typically do this in the hospital. When it's time for us to get new ventilators, a lot of times they will ask the staff to evaluate, give us your feedback. And they'll bring some of the new ventilators in, and they'll be in for a week or two, and letting the staff try them out. And then your director will say, okay, give me some feedback. You know, maybe there's a little survey or something after. What did you like? What did you not like? What was the benefits? Was this easy? Was this difficult? You know, and then compare it to something else. And trust me, we all end up having our favorites, things I like about this one, but there's other things I like about this one. I wish I could marry the two to make it all the one perfect ventilator. But you have to weigh the benefits. Some of them could be, well, can this one deliver Heliox? You know, this one can, this one can't. All right, well, we see a lot of patients who we use Heliox through. Maybe that's a reason we should choose this ventilator because it can deliver Heliox. If we have to give a nebulizer, because again, think about our patients who have these airway obstructions. It could be your severe asthmatic. Their airways are so bronchospastic and swollen, the airway diameter is extremely narrow and extremely small. So we give them Heliox. Okay, that's good to try to get the oxygen down there, but now we need to treat the bronchospasm. So I have to give them a bronchodilator. Well, if I go ahead and give them a standard bronchodilator, what do I do with the non-rebreather? I have to take it off. And here's your treatment. Meanwhile, now they're not getting the Heliox anymore. So we can actually set the non-rebreather up to use a nebulizer with it. Okay, so this is still your non-rebreather. We've added a small volume nebulizer with it. All right, so that can still, so they're still getting the Heliox from here because this is connected to Heliox, right? Providing the bag with Heliox for the patient to inspire. The nebulizer is now going to be powered with Heliox, because I don't want to give it room air or just oxygen because that's going to dilute the helium going through here. So this could be delivered with Heliox as well. But notice what I said about the flow powering the nebulizer. When we typically say a standard nebulizer, the flow needs to be 6 to 8 liters a minute, whether you're using oxygen or air. If I'm running it with Heliox, because it's such a very light gas, I need to run it at 10 to 12 liters a minute to get the same effect of the nebulization if I run it with Heliox. And so it's always interesting when we're using Heliox because we typically just don't have one tank. We have multiple tanks of Heliox and they're all there in the room, all there at the patient's bedside. One powering the non-rebreather. And what liter flow should the non-rebreather be running at approximately?
At least 10.
At least 10, if not more, right? To make sure the bag stays somewhat inflated. So that tank that E cylinder is running at minimum 10 liters, 12 liters, 15 liters, perhaps. Now I got the other Heliox tank powering my nebulizer running at 10, 12 liters a minute. And so we can go through Heliox very, very quickly. So yeah, I'm bringing in multiple tanks of Heliox.
Is that just a white piece that you connect? Like,
We steal it off the ventilator circuit, but you didn't hear me say that.
okay.
Because I just wasted an entire ventilator circuit popping off the Y, right? And I can utilize it. I can use that for both. So notice what we did here. We actually took the bag off the mask, put the Y in, reconnected the bag back, so I have a chance to bleed in some of that medication through the nebulizer. All right, questions? When's the test? Wednesday. Okay, just making sure you guys remember. Wednesday. All right, I do have a few questions. Few being the operative words, so if you want to take pictures of these things, you're more than welcome to. But let me go start them now, because there are many questions today. I'm not being sarcastic. All right, so first question. All the following are major precautions and hazards of supplemental oxygen therapy except, so this is from part 1. Oxygen toxicity, depression of ventilation, retinopathy of prematurity, or oxygen-induced encephalopathy. All are major precautions and hazards of supplemental O2 except D. Except D. So be careful of the verbiage, be careful of the wording, because you know me, I'm going to take some of these words and I'm just going to twist them around a little bit where it sounds kind of close, but it's not the same. Because wasn't there an oxygen-induced hazard? What was that word? Oxygen-induced? Mic check. Hello, is this thing on? Oxygen-induced hypoventilation? Oh, yeah. Okay, so careful. I just replaced the word hypoventilation with encephalopathy. I didn't trick you this time, but I'll get better on the test. How about that? All right, next question. The most suitable oxygen delivery device for a patient with an unstable minute ventilation needing a precise moderate FiO2 is nasal cannula, simple mask, air entrainment mask, partial rebreather mask. C, are you sure?
Yes.
Yeah.
The question is a fancy way of saying I need a high flow device. And you know that's not the way I'm going to ask it on the test. I'm going to ask it like this, right? So I gave you this so you can kind of see what is this? I could have said, which of the following is a high flow device, right? That's a gimme answer. It is C. But patient who has it, what does it mean? What's minute ventilation? What is minute ventilation? What's our minute ventilation? Amount of air we breathed in over the last minute, right? And what makes up minute ventilation? Rate and tidal volume. So if I have somebody with a rate or tidal volume that's all over the place, or an unstable minute ventilation, they need a high flow device. Again, remember, low flow devices are fine as long as the patient's breathing pattern is ideal. You know, if I said they had a stable minute ventilation, they didn't need a precise FiO2, a variable FiO2 is okay, then a low flow device would be fine. You know, and I have 3 low flow devices here: nasal cannula, simple mask, and partial rebreather. So a low flow device would be fine. But because I said unstable minute ventilation, or if I say a breathing pattern where they're all over the place, the respiratory rate is high one moment, low the next, tidal volume's high one moment, low the next, again, they're kind of all over the place. A high flow device would be best. All right, next question. The main indication for Heliox therapy is airway obstruction, pulmonary hypertension, pulmonary embolism, refractory hypoxemia, or ARDS. We even know what ARDS stands for? No? Acute respiratory distress syndrome. If we haven't talked about it, it's probably a good guess it's not the right answer here, which it's not. So what do we agree this is? A, airway obstruction. And I'll say this again. Does Heliox do anything for the obstruction? No. But it helps to get oxygen past that obstruction so oxygen can get down to the alveoli. So this one was A. Next question. Sorry. A recently extubated patient experiencing moderate hypoxemia is having trouble tolerating a 50% Venturi mask due to claustrophobia and airway dryness. When switched to a nasal cannula, his SpO2 drops to 88%. The physician wants the patient's SpO2 to remain at 92% or higher and asks the respiratory therapist what options are available for delivering moderate oxygen concentrations to this patient while maximizing patient comfort. High flow nasal cannula. Was a long ass question for high flow nasal cannula, wasn't it? Sorry. But what about the mask? Claustrophobic, airway dryness. Can you connect a Venturi mask to a bubble humidifier? No, absolutely not. Absolutely not. I mean, technically it will fit, but no, you're not supposed to connect a Venturi mask to a bubble humidifier. And so, again, claustrophobia, airway dryness, the standard nasal cannula didn't cut it, but yes, I can give any FiO2 I want with a high flow nasal cannula. All right, a few more. What do we got here?
No rebreathe or anything.
I'm making notes over here. All right, so we in agreement? Nasal cannula? Okay, nasal cannula. All right, I'll kind of go quick through here. Put that on the test 6, 7 different times. A few different people, different people wearing it. All right, what is she wearing? There's a face tent. There's a face tent.
She needs to be addressed.
Yeah, kind of dangling there on her chin. All right, face tent, but the large bore corrugated tubing. Why do you? She looks too happy. Yes, I agree. Looks too happy to be wearing this. You're expecting somebody with a face tent to have some sort of busted up face or something like that, and can't tolerate any other way. All right. Next question. What are they wearing?
Air entrainment mask.
It is a Venturi mask or air entrainment mask. Air entrainment mask. I forgot to mention this when we were talking about Venturi or air entrainment mask. I know this picture is horrible, you can't see it. There's an adapter that can connect to those colored adapters. There's a large opening here on the side that's the same size of this corrugated tubing. You can actually bleed in bland aerosol here if the patient needed moisture. If the patient needed moisture. And here's my response. What I needed to build that system, that bland aerosol system, to bleed in here, I would simply say, I'm going to disconnect from here to here and connect that bland system right to her aerosol mask and dial in whatever FiO2 she needs. If it's 50%, then I'll dial in 50%, as opposed to having to bleed in here. Again, that's what it's there for. That's what it's there for, but you don't see people use it. All right, so this was B, air entrainment mask. Next question, what does that look like? There's a T-piece. There's your T-piece. All right, there's your T-piece. Next question. There's your high flow nasal cannula. Again, if I just gave you this picture, you probably could guess high flow cannula, but it could be, without seeing the rest of it, could be assumed, well, that could be a standard nasal cannula, because some of them look pretty normal, like a standard nasal cannula, until you see the rest of it. All right, so this was high flow nasal cannula. Everybody okay with snap that picture? All right, next question. What's this little one wearing? That's a trach collar. That's a trach collar. You mean it's not F? It's not a nasal catheter? No, okay, okay, that's right. That's down there. That's right. All right, next question. What's he got? He looks so happy with it too. When you take his jacket off. And it's not plugged into anything. So, yeah, here's your reservoir. Again, I'm looking for the word pendant cannula, but that wasn't an option. Reservoir cannula, but it's the pendant style. How big and bulky the pendant cannula is. What's she wearing? Simple mask, and I'm gonna say, I bet you she needs more flow. How it's fogging up. It's probably she was just putting this on post for a picture. But yeah, needs minimum liter flow.
10.
Minimum liter flow.
5.
5. And at 5 liters, what does that do?
It prevents from rebreathing CO2.
Okay, so it helps to wash out the CO2, helps prevent the patient from rebreathing their exhaled CO2. All right, next one. What is that? Bonus. Bonus question. There's the original nasal catheter. This one's made out of rubber. 1920s era, in case you were curious. AERC has an online museum where, in case you're curious of any historical devices, they have oxygen devices, aerosol devices, all kinds of mechanical ventilators, all this stuff. You can go back and look through all and see all these pictures of old stuff. This was a 1920s era nasal catheter, again made out of rubber. You wonder where your standard nasal cannula got its start? How about the metal nasal cannula? I'm going to put this headband on you, buddy, and we'll run the oxygen tubing going someplace else. Again, made out of metal, so what was cold and would have to be reused. Okay, we're taking this one off you, and the next person that needs it, Haley, come here. You need some oxygen now. You know, and I'm curious at the time, how did they process? How did they clean? Rinsing under some water and then shaking it off, and here's the next person. But so these were all obviously oxygen devices from this chapter, lots of different ones. But when you look at the expected oxygen usage in the next 10 years, in the next decade, this is global, so this is worldwide. Look where we are now, around $41 billion of oxygen devices. Anybody looking at investing? I can set you up with the guy. In the next 10 years, up to 66 billion. And why? Why is this oxygen usage expected to keep climbing?
Vaping.
I'm sorry, I heard so much. I
said vaping.
Vape, okay. So
More people.
illness, more people, more illnesses. Aren't we supposedly living longer? You know, gonna require some of this stuff. You could say, well, the pandemic and all that. Again, truly the pandemic and the damage that had occurred to certain people that survived the pandemic and the damage that was done to certain individuals' lungs. Could this be, in another decade, we're seeing more of that use occurring? Plus, think about the home care world. Having oxygen where people can still have it in the home and not have to be hospitalized to receive oxygen. Again, better devices in the home for oxygen therapy, oxygen usage. So that's my 2 cents for what it's worth. Questions? No questions? You tapping out on me already?